Thank you all for joining us for today's webinar on the role of the primary healthcare team in overactive bladder. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar, which was made possible through an independent educational grant from Estella. Before we begin, I would like to share how you can receive continuing education credit for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link in the webinar's chat box. You can also use this box to enter questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from ARHP's education team with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Stephen Krause and Ann Moore, today's presenters. Dr. Krause is a professor and vice chairman of the Department of Urology at the University of Texas Health Science Center, where he heads the section of female urology, neurourology, and voiding dysfunction. In addition, Dr. Krause heads the neurourology and urodynamics unit at the Spinal Cord Injury Center at the Audie Murphy VA Hospital and serves as medical director of the South Texas Pelvic Floor and Bladder Center. Dr. Krause is widely recognized for his roles in education, which include program director for the 2-year fellowship in female urology, neurourology, and voiding dysfunction at the UT Health Science Center, service on the American Urological Association Urology Core Curriculum Section for neuropathic bladder, and participation in educational committees for the Society of Urodynamics and Female Urology and the Texas Urological Society. Ann Moore is a dual certified nurse practitioner in adult and women's health. As a practicing clinician, she has maintained an active ambulatory OB/GYN practice in Nashville since 1990. More recently, she was the women's health clinical trainer for the Tennessee Department of Health. Since February, Ann has served as Senior Medical Science Liaison with AMAG Pharmaceuticals. A fellow of the American Academy of Nurse Practitioners, Ms. Moore speaks internationally on topics related to the healthcare of women. We are thrilled to have them with us today, and I will now hand it over to Ann.
Hello, everybody. I'm pleased to be with you today. So this is a little bit about our disclosures. As Jessica said, I am with AMAG Pharmaceuticals, but we have no products now or in the pipeline that I'm aware of that deal with this particular subject area, so no conflict of interest in that regard. Here are our objectives. At the conclusion of this program, participants will be able to describe the role of patient education in overactive bladder prevention and treatment, demonstrate effective counseling skills in order to facilitate conversation about OAB, recognize the signs of OAB and formulate an appropriate differential diagnosis in order to provide evidence-based care, provide pharm and non-pharm treatments, emphasizing adherence, and then develop strategies for patient-centered care, including when to refer to a specialist. So what is overactive bladder? And as a clinician in Nashville for a number of years now, this definition has changed a little bit, and I think what we tend to as clinicians, we focus on stress incontinence or urge incontinence. And as we go forward, I think you'll find that it's not quite that simple, and that oftentimes folks have what we call mixed bladder issues. So for our definition purposes, urinary urgency with or without incontinence can go under the heading of overactive bladder. Frequency, so voiding more than 7 times in 24 hours, or nocturia, awakening one or more times at night to void. Urgency, of course, is defined as a compelling urge to urinate, which is difficult to defer. If you all remember those cute commercials, gotta go, gotta go, gotta, we're all laughing thinking this is really funny when it's actually not. And for those of us that have been in the clinical arena for a while, we recognize this. I'm always astounded sometimes at how some of this translates, if you will, to the broader population about, gotta go. Well, yeah, and it's a real hindrance and can really impact quality of life.
This is Steve. I just want to echo that comment, because a lot of the times it's just people think it's not such a serious thing, but it really does impact people's quality of life.
Yeah, and mapping a bathroom is difficult, particularly for women. And I could go on and on about, and you all know that, it's not just about having access to a restroom or a bathroom facility. It's accessing one that you feel okay with. So, you know, you're driving down the road and you're like, I'm not stopping there, but we need to find another place in a hurry. So y'all can probably relate to that. Okay. So the normal micturition cycle, the bladder fills, okay, so the detrusor muscles relax, or muscle relaxes, the sphincter contracts, pelvic floor contracts, and then you follow this circle in a clockwise fashion. The first sensation to void occurs, so the bladder is half full. Urination is voluntarily inhibited until the appropriate time. This is body training. This is what we learned. Then you get the normal desire to void, and then obviously that releases with micturition or voiding. The pelvic floor relaxes. The detrusor muscle contracts. So it all works pretty well most of the time. So the three major types of urinary incontinence, as I was suggesting earlier, and this pie chart, I think, gives you a kind of a clear, hopefully a clear picture of this. So you've got stress urinary incontinence at 50%. And when I talk to patients, I say, you know, this is kind of an anatomy/architecture issue. And, you know, you'll find that women complain of stress urinary incontinence with activity, whether it's jumping, whether it's, you know, some kind of stress exercise, but it involves an increase in intra-abdominal pressure, and that facilitates, if you will, or potentiates this issue of stress incontinence. You have urge up there at 16% and then mixed at 34%. So sometimes people actually may benefit from treatment in one arena with the other being somewhat resolved. So as I said before, it's not specifically a cut and dry A or B issue here.
I would just add one more thing, is that it's often, that you don't have to go back though, but it's often age dependent. It just, from my perspective, it does seem, the study that pie chart came from was women from ages 20 and up to 60 and plus. And as women get older, a lot of times that urge component tends to become more of a dominant force.
Thank you for that. This is a slide that looks at the prevalence of overactive bladder. And you can see it's a pretty wide range with men and women, but women tend to be the losers primarily on this in this particular setting, with having more problems, with 43% being the upper limit that's shown in this particular data set. But we don't, if you're in adult primary care, we don't want to ignore the fact that our male colleagues and friends also experience these problems. There is an increasing probability or likelihood with age. So over 30% of folks affected are age 65 or older. 63% of OAB patients are continent. And I think what tends to happen is that folks don't seek care unless they have the actual problem of leaking or having a quote, accident, unquote. And that's unfortunate, because it certainly is, as we suggested before, a quality of life issue. 37% of OAB patients are incontinent, so higher urge incontinence among women. And so, you know, again, I don't know if y'all remember June Allison, and I'm really digging back into the past here, but she was the Depends undergarment, what's the word I'm looking for? She was their spokesperson for a number of years. And we've normalized this, I think, to some degree. So hopefully this presentation will enable us to move beyond that so that we can actually help people in a more definitive and effective way. Prevalence of OAB compared with other chronic conditions. You can see overactive bladder at the top, followed by arthritis, kidney disease, chronic sinusitis, and so forth. Unfortunately, as you'll know, this is not well identified or not well treated, because folks tend to not seek care, as we'll discuss in a bit. So, you know, what the actual number might be, I think is this may be actually a low estimate, but I think that we need to empower folks to come forward with some of these complaints, because they may be, again, we've kind of normalized this, I think, and this gives us an opportunity to bring it into the equation of healthcare. Okay, OAB, falls, and fractures. All right, and I actually like talking about this one because what happens, particularly in folks as they get older and they're experiencing that that sense of urgency, And, I don't know if you all have experience with this, but, personally I can remember my parents not having a good lighted pathway to the bathroom. So, what happens is you get up, you got to go, you run to the bathroom, you trip over something on the floor, and you sustain a fracture because you've fallen. So this is, clearly, it's not just about something that, oh, well, it's not life-threatening, we'll deal with this down the line, because we're talking about diabetes, hypertension, and all kinds of life-threatening issues. But this actually can be one based on just this this comorbidity that can occur because someone's rushing to the restroom. So just put that in sort of the diagram, if you will, when you're talking to folks, and also get into the issue of fall prevention, which has to do with osteoporosis and bone health and so forth. But also, you can certainly have an injury when you're rushing and aren't prepared.
So, Ann, can I add one thing? And OAB is really prevalent, but no one pays attention to it. All providers, primary care, everybody, deal with the serious problems, but no one tends to think that OAB is that serious. But then when you start talking about falls and OAB contributes to it, it really comes in. So.
Yeah, and I understand. I get it that people, that clinicians, given the time that we have with patients, we prioritize. And, you look at the worst scenario first probably, and then you go down the list. But I think we need to move this one up for just those reasons of, the consequences that can occur other than just quality of life. And I don't mean that is in just quality of life. But
and all the providers are good providers. We assume that, but a lot of because of the time constraints that you just mentioned, a lot of times the provider will think, well, I don't need to bring up OAB because I'm sure the patient would bring up OAB if it was really important, right? But right. Patients don't do that. They only do it when it's really, really bad.
Right. I completely agree. So quality of life, daily activities, work productivity, restroom or voiding, mapping, and we'll talk about that from an intervention perspective. But, clearly people become, can get to the point where they're reclusive. They have certainly an impact this has on sexual function. They may experience depression, anxiety, clearly if they're concerned about having a large accident. And so, the overall, the umbrella of quality of life is very impactful, and particularly if you look at all of these facets that come under that. So if we can assist folks in getting good intervention and resolution of OAB, all the better for all of these features that can show up as a result. All right, take it away.
We've been making an argument about why OAB is important to pick up, diagnose, and treat, but despite the fact that it's important, we really don't see the OAB treatment as often as we should. A lot of times it's just not getting done. And why is that? Well, again, part of it is what we alluded to earlier. It's not that serious of a disease, right? So we wouldn't treat it, or it'll only be serious enough if they bring it to our attention. But some of it's also on our part. It's, we may not be doing as good of a job educating our providers on picking up on it, little subtle signs and such. We talk about sleep and quality of sleep, but maybe one of the reasons their quality of sleep isn't so good is because they're waking up 3 or 4 times a night. We know that there are studies that have shown that if you wake up more than twice, you decrease your quality of REM sleep. So those things are in it, but we're not trained to pick up on it. Dismissing the impact on the quality of life, that's what we were alluding to earlier. That's just the bladder. It's not that big of a deal, but it really is. Ann mentioned earlier about the bathroom mapping. It sounds kind of silly, but you know what? When your patients dictate where they go, or the first thing they have to think about is, where's that bathroom? That's actually a really significant impact quality of life. I'll see patients and I'll ask them, can you sit through a whole movie? Is your bladder that bad that you can't even make it through a movie? They look at me and they're like, I don't even go to the movies because I can't go to the bathroom in time. So quality of life is big. I can't go to the movies because my bathroom's my bladder's that bad. That's an impact on quality of life that we're not addressing. Some patients think it's just, patients and providers think it's part of natural aging. My parents had it, so as I get older, I expect to get it too. That's not. We know it increases with age, but it's not necessarily something you have to live with as you get older. Treatments aren't effective. Well, in the olden days, they probably weren't that good. We had medications that were okay, but they had poor tolerance issues. Sometimes people think it's only fixed with surgery, and they don't want that, but that's not true. We have great medications, we have great behavioral therapies, and much better abilities to teach them now than we did before. Providers being unaware of the other diagnosis or the fear that they're going to miss something. We have a couple slides on that, which we'll get to, but really the ability to diagnose OAB is very simple. It's a history, and it's a physical exam, and it's a urinalysis. And we don't consider the potential complications or the consequences of this problem. I've had patients come to me who had such severe leakage that they actually had I'm blanking on the term, but like a keratosis of their perineal skin that actually a gynecologist actually biopsied thinking that it was cancer, and it actually was just really a severe diaper rash. And that's how serious it can get. The falls and fractures we talked about, skin infections. If your urine is soaking in skin, you're going to end up getting fungal infections and such. So it's a serious problem that we need to really focus on. Next slide. So from the patient perspective, they also, a lot of what we just talked about, patients see as well. They don't think it's something that they really need to treat, or they're afraid of the treatment, so they may be a while before they actually surface to the provider. The provider didn't ask them about it, and the patient list let it go for a couple years. You can see there, at least 3 years before they mention it to you. That means 3 years of lost quality of life, or quality of life that could have been improved upon. And then you see the motivation to seek help is often related to symptoms. The worse it gets, then the more likely they'll come bring it to you. The level of bother, that's a key point. I have had patients who have bad symptoms as far as I'm concerned. If it doesn't bother them, then they don't need to treat. I mean, if they wake up 3 times a night, I'm not happy waking up once a night, but 3 times a night and they're saying I'm okay with it, then you don't need to treat. If they're waking up, if they're going to the bathroom 11 times in a day, that by definition meets the criteria for frequency in OAB, but if they're not bothered by it, you don't have to treat. But a lot of times that's what drives them in. And then age, yes, as they get older, they just, they're able to tolerate it or deal with it, but as they get older, it's just too much for them. So there's a last bullet, men are more likely to initiate the conversation with the healthcare provider. So some of that's just some taboo stuff that really I wish we could break through, because it's okay for men to talk about it, because probably they're thinking it's their prostate, and it very well might be their prostate. Men often have just prostate symptoms, or they could have a mixture of urinary symptoms that are due to prostate and OAB, which is still easy to treat. So, but that's something that's a shame, that because it's for men, it's not as taboo for them to bring it up as it is for a woman or for a female. So that's something that would be nice if we could break through. Next slide. More on this. They're embarrassed, the stigmata. They don't go out. They're thinking their symptoms are normal. They expect it to occur. They have to live with it. It's part of aging. The treatment, again, from their perspective, that they don't have treatment. We don't have treatments to make them better. And they're hoping that the provider is going to bring this up as opposed to them bringing it up. Next slide. So presentation. So yeah, the patient's not going to come in and say, I have OAB. But what they will do is they will come in and say, I am bothered by my bladder. I wake up too often at night to go to the bathroom, or that's probably one of the more common ones. I go very often. I can't hold it. When I get the urge, I got to run, or I leak. So that's one way. Sometimes with the direct-to-patient advertising, they may pick up on it when they see the commercials on TV. They can come in and say, I have some of those symptoms. Some of the ones the patient may bring up during their well visit or their annual visit or such, and the provider may pick up on it. Or with a little luck, the provider may actually ask about it. So those are the ways. Next slide. So what are we worried about? So let's pretend that we've overcome that hump, and now we're talking to the patient, and you as a provider are probably worried, or hopefully not, but maybe worried about what are you going to miss if you diagnose OAB, or as opposed to why shouldn't you send this to a specialist? Well, these are the things that you should be thinking in the back of your mind that could or couldn't be, but they're pretty easy to get through. Urinary tract infections. I mean, we do want you to get a urinalysis on your patients when you have the potential OAB. So you'll find out if they have a UTI pretty quick. Plus, they tend to have not just a frequency urgency picture, they often all have a burning or a pain with urination picture. Stress incontinence. That's the one that kind of has some overlap, as Ann was mentioning earlier. There's patients who have mixed incontinence. They have urge and stress. and then sometimes they just have distress. And the key difference here is I leak urine when I cough or sneeze or lift something heavy. That's stress incontinence, as opposed to I leak urine when I can't make it to the bathroom in time. As I get to the door of the bathroom, I put my hand on the handle and it's coming out. That's urgent incontinence. With a little bit of questioning, it's really, you should be able to decipher it pretty quick, pretty easily. So pelvic organ prolapse spooks people because, you know, we don't want to miss prolapse. But honestly, I would argue that there's multiple stages of prolapse. There's, you know, grades 1 through 4 technically, but 4 is really, really bad. 1 and 2, I would argue that if the patient has a grade 1 or 2 prolapse and they have OAB symptoms, I'm not going to be saying I need to treat that prolapse to make their OAB symptoms better. I would be treating their OAB and not doing anything about the prolapse. It's the grade 3s and the grade 4s that are going to be a problem. And usually they have other symptoms when they have grade 3 and grade 4 prolapses. They have vaginal bulges. They'll feel something in between their legs. They'll say, in order to pee, I have to push it back in. That's not hard to pick up. So I wouldn't be worried about missing a prolapse. Neurogenic bladder comes in multiple different flavors, so to speak. You can get neurogenic bladder from a stroke. I would argue that if you have that, you just have a really bad case of OAB, and primary providers should be treating. You don't need a specialist for that at all. They just may require harder therapy or more aggressive therapy, maybe combo or such, but they are just really bad OAB. MS could be a little bit more complicated, but there have been enough studies that have shown that for females with MS, you really can't hurt them if you treat just their symptoms. Men might be a little bit more complicated, and then when you have spinal cord injury, Parkinson's, those are a little harder. Even Parkinson's with females probably okay to treat, but if you have like a spinal cord injury, that may be the one time that a specialist should be involved. Post-surgical, that's another one. If someone had a sling or other uro-gynecological surgery done, say a month or 2 ago, 3 months ago, they didn't have OAB symptoms before, but now they do, I'm really worried that the surgery has had some unintended consequences, and I would probably want to have them come back to their surgeon. On the other hand, if they had some sort of gynecologic or urologic surgery 3-4 years ago and now they have OAB symptoms, it's probably not related, or at least I would be treating them for their OAB first and then pursuing workup if they didn't get better, so you guys can do that as well. Interstitial cystitis, that's where there's some overlap in the symptoms between IC and overactive bladder. They both have frequency, they both have urgency, they probably both have nocturia. Where the difference is IC's hallmark symptom is pain. Bladder pain is their predominant symptom. Patients will tell you, I just can't get comfortable, I'm always in pain, I pee, when I pee it hurts, I pee out razor blades. Those are real life quotes. So if your patients are saying that, they probably don't have OAB, they probably have more of an IC picture. That being said, IC is also a diagnosis that can be treated with I mean, there's overlap, I should say. There's overlap, and they have the frequency urgency symptoms, and that's not something that you should ignore either. Pelvic cancer, you know, that it's going to be kind of rare, where a gynecologic primary cancer is the presenting symptom for that is OAB symptoms. Bladder cancer, on the other hand, that would be a concern, but how are you going to pick that up? That urinalysis. So if someone had a urinalysis and it's got some hematuria, blood in it, that one requires an evaluation. But if they have a negative UA, I probably would be okay. And then vaginitis really is not going to be so much urinary symptoms as it is vaginal discomfort, vaginal pain, discharge, and such. Medical causes, it's a bad day when I get to diagnose diabetes, and I get to do it a couple times a year because they didn't know they had it, and they've got horrible glucosuria, and their sugars in the 300 to 400 range, and they don't need OAB treatment. They actually need their diabetes treated. But the ones that are, I guess, more interesting or harder are the ones who think they're well controlled when they come in and they still have high glucose in their urine and such. The one thing that's different in the last couple of years is the new medications, the SGPL2, I think they are. I'm not sure. They're the ones that make you get glucosuria as a way to get rid of your sugar. You have to make sure they're not on that kind of medication. Congestive heart failure, how is that going to cause OAB symptoms? Well, it typically will cause polyuria and nocturia. And what happens is the patients will have, congestive heart failure, they get peripheral edema because of it, so they get the swelling in their legs, and then they sit down or they lay down, they go to sleep, and all that edema has to go back into their bloodstream, and now they become hypervolemic, or they have too much volume in their bloodstream. They got to get rid of all that excess fluid that was previously in their legs, so they'll diurese that out, and then they have to pee to get it out. So that when patients tell me they have primary or significantly their major complaint is nocturia, and I look at their legs and they have swelling, I'm going to be saying you probably don't need your OAB treatment. You probably need to talk to your primary care provider or your cardiologist about better CHF treatment, maybe stockings, supportive hose. Actually taking a nap or raising your legs in the middle of the day actually can do wonders, because they do it in the middle of the day, they get rid of that edema in the afternoon, because then they pee it, and then by the evening comes, it's not as bad. Next slide. So the history, like we said, is pretty simple. I have a problem with bladder control. I go too often. I have urgency. I have frequency. I wake up too much at night. And the numbers are more than 7 and more than 1, and whether there's a bother involved in it or not. You can list it whether they have the other medical problems that we talked about, the diabetes, congestive heart failures, and such. But the urologic questions, or I should say the uro-gynecologic questions, are pretty simple. Frequency, urgency, does it bother you, and leakage. And if you do leak, does it leak when you cough and sneeze? How much it bothers you. Physical exam, I mean, we all do physical exams. There isn't much to it. If you really are looking for prolapse, if that's your concern, you can. But like I said, I would argue that if you have grade 1 or grade 2 prolapse, unless something is significantly bulging out of the vaginal introitus, even if they have mild or moderate prolapse, it shouldn't really factor into your concerns for OAB. Urinalysis is the one test you really need to get. You want to make sure they don't have blood in the urine. You want to make sure they don't have a UTI. And you also want to check to make sure if they have glucosuria or not. Bladder diaries are great when you can get them. I advocate for them. They really do help. You can use them as a mode of treatment as well. The problem is that getting patients to fill them out can be difficult, but you really got to push them, because I've had patients learn their behavioral therapy just by doing the diary. I don't mean to be cold or to be simplistic when I say, the patients don't always understand this. I had a full glass of water right before I went to bed. I wrote it down in my diary, and I realized, you know what? Every time I have a full glass of water, I wake up 2 or 3 times then. But we see it, but they don't see it. It's not as easy for them to make the connection or not. Sometimes it is, and they actually go overboard the other direction and cut back on fluids, which is not good either. But sometimes a simple thing like, you're having a full glass of water before you go to bed according to your diary, and I noticed that you are taking a pill. Well, you don't need a full glass of water to take that pill. Cut back on your fluids. I'll often tell patients, look at your diary, calculate the amount of fluid you drink from dinner to the time you go to bed, and just cut that in half, just for a couple days to see how that works. Additional tests that you can get if you think you need to: urine culture, maybe if your analysis has been positive multiple times, you're worried about recurrent UTIs. Post-void residual in females, typically not required. If you have a lot of primary care providers have bladder scanners in the office. If you have one, you can check. I might be more concerned if the patient had previous history of retention problems, or maybe they have a neurologic diagnosis and you're a little worried that maybe they're not emptying so well. If you are talking men and you're dealing with male lower urinary tract symptoms due to BPH and OAB, a PVR can help you there. But again, for females, it's not really as required. Next slide. So differences between the different diagnoses we've been talking about. I mean, I mentioned this earlier. If you have OAB, urgency will be present in OAB. It really won't be present in stress incontinence. It may be present in UTIs. Frequency in OAB, in UTI, not in SUI, stress incontinence. Leaking with physical activity, sometimes with OAB. A lot of times their bladder's going because they have the contraction or they have an urge already, and then they just do something and then it squirts out. Stress incontinence for sure. UTI, no. Amount of leakage with OAB can be variable. With stress incontinence, it can be variable. With UTIs, it can be small. I would argue that variable with OAB, a lot of times the accidents are significant. They can be significant, and that's a hallmark for sometimes that. Urge incontinence for OAB, up to a third of the time. In stress incontinence, it's not going to be urge incontinence, it's stress incontinence. With UTIs, it's possible. Nocturia, OAB, yes. Stress incontinence, maybe, maybe not. It's not part of the symptom complex as much. And then UTIs, usually. And then an abnormal urinalysis and culture, normal with an OAB, normal with SUI, abnormal with urinary tract infection. Next slide. So for prevention, A lot of it is getting patients educated, getting them aware of what they really should be doing, where they should be in terms of their symptoms and such, getting the idea of what's normal. I've had patients come to me with nocturia ×3, and I put them on OAB therapy of one kind or another. They come back and they're waking up once a night. I'm thinking we've made big headway, and they're like, well, I'm still waking up once a night. I mean, that's not that may be an unrealistic expectation, or going to the bathroom lasting more than 4 hours. That might be an unrealistic expectation. Getting them to understand that it's not part of normal aging, getting them to talk about it. Next slide. So when you're seeing the patients, you know, again, with the limited amount of time you have, I would advocate find one question. If you're relying on the patient to bring it up to you, we're doing them a disservice, because they're only going to bring it up when it gets really, really bad, and they're going to be living with it for a while. So if we could get it out of them, I would advocate getting one question, kind of all-encompassing, maybe for stress and urge incontinence, and then if they say, no, I got no problems, then you've done your diligence and you can move forward. But a question like on the bottom, I particularly like the, are you bothered or worried about your urine control? Because that opens up the floor for everything. And if they say no, go on. If they say yes, then you can delve in. Is it more of a stress incontinence picture, or is it more of an OAB picture? And then you can go into the other questions. Are you waking up at night? Are you going to the bathroom so often that it interferes with your activities? Like I said before, patients who can't go to the movies because they're afraid to go to the bathroom too many times, that's a problem. Do you leak on the way to the bathroom? That's classic for urge incontinence. It can be with stress too, but a lot of times it's, every time I'm on my way to the bathroom, it's coming out. And then the strong sudden urges to urinate, that's a hallmark symptom for OAB as well. Next slide. Next slide. So the exam is pretty much general exam, and we talked about the urologic gynecologic portions of it already. Neurologic, it's pretty rare where overactive bladder is going to be the first symptom of some neurologic disease that you don't know the patient already has. So if the patient comes to you and they've already got a diagnosis of MS, multiple sclerosis, or Parkinson's, you're going to know that already. A neurologic exam is not going to help you too much. On the other hand, again, there are occasions, rare as they are, that OAB may be the first presentation of some neurologic disease. A quick glance, you know, is their gait normal? Do they have pins and needles and such like that? You guys know how to do neurologic exams better than I do, so you're already doing most of it anyway. Neuro-urologic exams, there are things that you can do to try and pin it down more, so to speak, but I'm not so sure how much it's going to really contribute. I don't do bulbar cavernosus reflexes on most of my patients. I don't do sacral nerve testings and pudendal nerve testing, such like it's just not going to make much of a difference with the workup for OAB. Next, so most of it's just general. Next slide. Vaginal exam. If you're doing them again, we're looking for prolapse, but again, mild or moderate, it's not so bad. Assess for normal sensations and such, reflexes. Vaginitis. If patients have vaginitis and they're mistaking it for OAB, that's something that you can easily fix and then make it better. Masses and tenderness will be obvious. Urethral diverticulum, that one is a little less obvious, but when you do your exam, a lot of times you'll see a little bulge just proximal to the urethra, and it could be mild, it could be the size of a marble, it could be a little flatter. These patients will often have recurrent UTIs. They'll also tell you that bulge, that area, is tender to palpation, and if they have intercourse, they'll have pain. So again, as a presenting sign for OAB, it's not too concerning. Next slide. Oh, actually, you can go on, but the one thing you do want to worry about, many women as they get older will have, you know, postmenopausal symptoms, and some of them can be due to atrophic vaginitis. So you want to make note of that, because those sometimes have some overlap with urinary symptoms. They'll have vaginal dryness and they'll have pain with intercourse and such, but they also may have some irritative urinary symptoms like frequency and urgency symptoms. And interestingly, that patients will tell you if you treat their atrophic vaginitis with a topical estrogen cream or other therapies, sometimes the urinary symptoms may get better. If nothing else, perhaps it'll help augment as a combo therapy when you treat the OAB as well. So this is the algorithm, and it kind of follows the guidelines for overactive bladder that were put out within the last couple of years. History and physical and urinalysis are the key components or the mandatory components. You can do additional things like a culture and a post-void residual. The first line therapy or tier 1 is patient education, making your patients aware of what normal urinary physiology should be, what the bladder is supposed to do, what's normal, what's not, what's a normal amount of fluid intake. I mean, I've had patients drinking 2 liters a day, and I know, we push fluids and hydration is a good thing, but sometimes it's a little too much. Behavioral interventions, what can you do to decrease your OAB symptoms without any exercise therapy, without any medications? Things like dietary modifications, cutting back on bladder irritants, soda, caffeine, carbonated beverages, cutting back on fluids, especially excessive fluids in the evening, especially if natriuria is their bothersome symptom. If that does it, then great. You're just taking care of your patient with a behavioral plan and just follow them up. If it doesn't, you can get more extensive. You can do pelvic floor exercises where we actually will do pelvic floor contractions in order to abort bladder contractions. We'll go over that in a second. And then if that doesn't work, then the next step goes to pharmacologic therapy, and we'll go into that and then when to refer. Next slide. So this is pretty much what I just reviewed. Bladder health literacy, meaning patients should have a better understanding of what their bladder really should and shouldn't do, get their expectations. If they do understand expectations, they'll have better adherence. They're put on, for example, if they were put on a medication and they get improved, but they didn't reach their expectation because it was unrealistic, they may just say, oh, the medication failed, and they'll stop it. Or they didn't get better with behavioral therapy and in their eyes, and then they'll just stop it. And you really got to stick to it. Behavioral therapy should be offered to all patients, and all providers, nurses, health educators, caregivers, are able to provide support for this. And there's lots of places to get support for this. Next slide. So the diary. The simplest diary is going to be a frequency diary, which will report the time of the void, maybe with an urgency scale. Voided volume is probably better, or not probably, but better, in terms of if they can measure their voided volumes, you can get an idea of how much they're holding on each time. You can add a intake diary. I call them intake-outtake diaries, so that you can get an idea of how much fluid they're drinking, get an idea of whether their symptoms are worse in certain times of day relative to their diet. Maybe you can find something in their diet that could adjust. The description of symptoms, again, do they leak urine with an urge, or do they leak urine with a cough or a stress? And there are diaries that are pre-printed that have like check marks or scales that the patients can circle and identify which the type of leakage or OAB symptom they're having. And then patient education tools, pelvic floor exercises, again, they can help especially if they're doing dietary modifications. Next slide. So behavioral intervention falls into different types. Just getting them to void on a more timed regimen can help. If a patient can usually make it 2 or 3 hours, getting to void on the Q2 hour mark may help avoid accidents. Some professions don't allow them to have access to a bathroom, but by the time they do get to go, it's too late. Their bladder's already going. So getting them in a situation where they can go on a more time plan, helpful. Older patients who are in facilities where they may have limited access to a bathroom because they have mobility issues, they need a provider or a care provider to help them get to the bathroom. Getting that facility or their healthcare providers to help them go to the bathroom every 2 hours is a good way. I choose 2 hours just because it's 2 hours, it's easier for patients to remember. I tell them every even number on your clock or on your watch. Urgency control strategies. So there are things where you can learn how to control the urges. You'll see in the next slide where they call it the Knack. Every different pelvic floor therapists will call it different things. The Knack is one way to call it. We call it a quick flick, where you basically learn how to contract your sphincter so tight and strongly when you get the urge. What happens there is the bladder sees that the outlet is closed. The sphincter is closing down. The bladder is a relatively dumb organ, but the one thing it does know that if the outlet is closed, it shouldn't be contracting, and that's how you can capitalize on it and even take advantage of that reflex so that you can then teach them to abort their bladder contractions by doing the Knack or the quick flicks. Next slide. Don't go backwards, but one of the other bullets there was the diary. The diary itself can be a reinforcing measure. They'll learn their symptoms. I notice my symptoms are worse an hour after I have my coffee or an hour after I have my nighttime cocktail. Okay, well, if you don't want to, if you want to do this with dietary modifications, maybe cut back on some of that would help. They'll learn that. The urinary symptoms that we're trying to improve, storage symptoms, are the frequency, urgency, nocturia, incontinence, bladder pain. The voiding symptoms tend to be weak stream, strain voiding. These are the symptoms that can sometimes, especially for a guy, for a male, if you're worried about BPH, they'll have more of a voiding symptom, but then they sometimes will have storage symptoms as well. So a male with BPH may present with just weak stream, feeling of incomplete emptying, and a dribble, post-void dribble. Whereas a male with OAB symptoms and BPH symptoms will have the weak stream and also the urgency frequency. My personal preference, I tend to treat the BPH first, wait a few months, see if they get better, and if they don't, then if they have an OAB pick, there you got to figure it out. Do they have more, if they have persistent symptoms after you've initiated a BPH treatment, is it more of a BPH problem or is it really an OAB problem? And if it's an OAB problem, then you treat the OAB. If it's a BPH problem that's persisted despite the BPH meds, then you may need to be sending them to a specialist. Next slide. This is what we talked about earlier, those secondary causes that may be causing OAB symptoms or contributing to them, and if you actually could address these symptoms or these problems, that someone get better. Again, I'm a believer that prolapse only when it's really, really severe would be contributing, and I don't think we're talking about that. But things like bladder cancer, stones in the bladder and such, you'll pick that up on the urinalysis. So again, if they have hematuria, recurrent UTIs, and that's one where you should send to the specialist because they'll figure that part out. The other problems you should be able to identify, their diabetes who are poorly controlled. You probably can help them more than the specialist can anyway. Next slide. This is the behavioral therapy, moving into behavioral therapy, the general principles. Again, have them do a diary at the beginning so you can kind of get a baseline of their symptoms, recognize any patterns that they're seeing. I alluded to that earlier. There's verbal instructions, there's pamphlets, there's different ways to teach them how to do these behavioral strategies and pelvic floor exercises. Going over their fluid intake, again, it's important, especially if they're excessive fluid intakes. They have excessive fluid intake. On the other hand, the one who's drinking 2-3 liters of fluid a day can be a problem because they're drinking too much. But I really hate seeing the patients who cut back on their fluid so much in order to deal with their bladder. That causes other problems. Obviously, dehydration is one of them. Constipation is a biggie. And a lot of times when they start dealing with constipation issues, that also exacerbates the bladder problems. So sometimes actually improving their fluid intake or increasing it makes their bowels better, but that bowel improvement then makes their bladder better. Next slide. So that's the Knack, and that's the teaching patients how to contract their pelvic floor muscles quickly and strongly. And again, it's precedent. It's based on the fact that the bladder is squeezing if the urethra and the sphincter are open, but if the sphincter closes, there's supposed to be neurologic reflexes that basically tell the bladder to stop squeezing. That's what normally happens. Well, when you teach these patients these control mechanisms, you're basically taking advantage of them or having them focus on them so that they can learn how to contract their sphincter muscles, abort their bladder contractions to benefit the OAB symptoms. So you have them when they get, go ahead.
Can I interface there and say that, the idea of running to the bathroom is probably the worst thing you can do
Yep.
because it doesn't give you a chance to, as you're saying, stop and get control of the situation as is outlined here in the Knack.
Yeah, so I always tell patients, when you have an urge to go and you're feeling like it's about to come out, your bladder's probably contracting or it's about to. And if it's a race between you and the bladder to get to the bathroom, bladder's going to win and you're going to leak. Yeah. So teach exactly what Ann just said. Get them to subside that contraction. Best way to do it, have them squeeze their sphincter muscles, the Knack, quick flicks, again, however you want to call it. That aborts the bladder contraction. Now the urgency will go away. Now they should go to the bathroom calmly. They shouldn't go back to doing what they were doing, at least not directly, but because a lot of times if they go back to doing what they were doing, the urge will come back again shortly, and it comes back with a vengeance that's even stronger. So get the urge to be suppressed, and then once it's gone, calmly walk to the bathroom. These patients may also have a little bit of a weak sphincter to begin with, so they're at risk for stress incontinence. And if they rush to the bathroom, they may also start leaking because of stress, because their bladder's full. But the urgent thing is very important. Like Ann said, get them to stop the urge, get it to go away, and then don't forget about it. Then just calmly go to the bathroom, and they should be able to hopefully they'll make it in time. Next slide. So avoid rushing to the toilet, which we just said. Recognizing what's going to trigger the bladder. They may have an aura or some urgency feelings or something that I'm going to be going to the bathroom soon. Breathe easy, take it calm. Do that quick flick so the Knack, control the urgency. Then once the contractions relax, you can relax your pelvic floor, hopefully, and then go to the bathroom nice, calmly, and hopefully you won't have an accident. Next slide. So we just talked about bladder training. You can do pelvic floor muscle exercises. Pelvic floor exercises really came to be as a thought that it would help stress incontinence to strengthen the pelvic floor muscles so you wouldn't leak. I don't think you're actually strengthening the pelvic floor muscles for urge incontinence, but where I do think it's helpful is a lot of these patients, if you ask them to do the contraction, they're contracting every muscle but the right one. So they may need help identifying which muscle to contract. That's where training pelvic floor exercises, maybe with a specialist, a therapist, a nurse, any provider for that matter, can do it. And I do it with my patients when I do their pelvic exam. So yes, when I do a pelvic exam, I actually will have a finger inside their vagina and I will say, let's just see how well you can do a pelvic floor exercise. And they're squeezing everything. And I say, you feel my finger? I want you to squeeze my finger. I want you to try and retain my finger. And that will reinforce, or it's a feedback, hence the word biofeedback, so they get an idea of which muscles to contract. If you don't want to do that, or if your patients are not in a situation where you could do that, tell them, pretend you're at a party and you feel like you're about to pass gas, what would you do? That's the same muscle that you want to get them to squeeze. They tend to figure that one out. And that's biofeedback. So next slide. If you really want your patients to get pelvic floor therapy with a therapist and you don't offer that in your practices, hook up with a physical therapy group in town or a specialty group in town that may offer it. They often do. Lifestyle changes, again, we just talked about fluid intake and avoiding excessive fluids, making sure you're not cutting back too much, avoiding irritants, coffee, caffeine, such, addressing the other health issues, avoiding constipation. There are studies that have shown that weight control, even actually attempting weight control, not even if you don't gain it, but if you don't achieve your weight control, but just attempting weight control will help improve OAB, or urinary symptoms, I should say. Next slide. Behavioral therapy really does require a patient to want to do this. So we want to, I'm a strong advocate of behavioral therapy, yet I'm sure I probably write more medications than I want to. And the reason for that is I also know that if I beat this to a drum, to a dead horse, and the patients are not going to do it, all I'm going to do is have a patient leave my office and not do their exercises and come back still suffering from OAB, in which case I probably should be offering them a medication, if nothing else, in conjunction with a pelvic floor exercise plan. But it does require the right motivated patient. If they don't want to do it, I'm not sure you're going to be able to convince them. You certainly can try, but you really, the right patient's going to want to do this. Skilled therapists we've talked about. The problem is it's not always covered, but we do the best we can. Next slide. I know we're approaching time. So pharmacologic therapy, there's basically two different two different medications, antimuscarinics and beta-3 agonists, and then there's botulinum toxin. Antimuscarinics come with a selective versus non-selective. Next slide. Different types of antimuscarinics. You've got darafenicin, which is an Ablex. It's immediate release versus an extended release. I'm actually only aware of an extended release. Toviaz, which is fesoterodine, which is an extended release formulation. Oxybutynin, which has an immediate release, which is oxybutynin IR or ditropan IR. There's an extended release oxybutynin SA or ditropan XL. There's a topical, or a couple topicals. There's the Oxytrol patch, the gel knee cream. the others, there's trade-offs between the orals versus the topicals. There's a little less of the systemic side effects. You also trade some skin side effects. Sulfenacin, which is Vesicare, which is extended release. Tolterodine, which comes as Detrol or Detrol LA, or Tolterodine IR and Tolterodine LA. So that's the IR and the ER versions. And Trospium, which is an IR, which is Sanctura, to give them full credit there, which is also, they have an immediate release and an extended release. Next slide. Beta-3 agonist, Myrbetriq, it's the first beta-3 receptor agonist for overactive bladder. It's approved in 2012. It's a safe and effective alternative to antimuscarinics. It's purported to have less side effects. It certainly doesn't have the dry mouth and constipation that the other medications seem to have. It works differently, and that's probably why it has less of those side effects, and it works differently on the bladder too. If you think about the antimuscarinics, they work by blocking the parasympathetic pathways, and if you want, the other way to treat OAB would be to activate the sympathetic pathway. The best way I describe it is parasympathetic systems enhance contractions to go to the bathroom and cause OAB, so you want to block that for OAB. Whereas the sympathetic system facilitates storage, and an agonist for the sympathetic system is going to facilitate or augment storage even more. Hence, a beta-3 agonist helps the bladder store better. Think if you always, the other way to think about it is that if you're in a high adrenaline state, the last thing you want to do is go to the bathroom. That's the sympathetic state, the oversympathetic state. Next slide. Combo therapy. So we talked earlier about behavioral therapy. The guidelines do talk about offering behavioral therapy, exercise therapy with or without an additional pharmacologic agent. I actually am a strong advocate of this as well. I've had patients, they get the quicker bang for the buck, so to speak, with the medication right away while they're doing their exercises. And they also will have a little reinforcement. Oh, my exercise actually might be working. Maybe it's the medication. Maybe it's the exercises. I don't care. They're getting better. And then they can maybe wean off the medication later on and continue doing those pelvic floor exercises. Unfortunately, I'll tell you, in reality, a lot of patients will stop the drug thinking they got better. They have to be aware that this is a disease process that will continue, whether they do one form of therapy or not. They have to do that. So either they have to continue doing the pelvic floor therapy, or they're going to probably have to stay on their medication. Next slide. When to refer to a specialist. So again, hematuria should be a direct go to the specialist. Don't pass go. You want to make sure they don't have bladder cancer. That does not get better with any of the treatments we've talked about. When the diagnosis is unclear, sure. Obstructive symptoms, if it's a male, treat their VPH. If their symptoms persist, you have to figure out if it's more of an OAB picture or an obstructive picture. If it's OAB, go ahead and treat. If it's not sure, send them to a specialist. Pelvic organ prolapse, if you think it's contributing to their OAB symptoms, then send them to the specialist. But again, I advocate grade 1, grade 2 prolapses usually don't. Not responding to your first and second line therapies, and we're starting to talk now about third line therapies like botulinum toxin, which is a minimally invasive based procedure, or neuromodulation, and there are different ways to do neuromodulations. Those are what we would do when the first and second line therapies don't work. Those should go to a specialist. Elevated post-voiding residual, so if you have a male or a female for that matter, where you did check a residual, if you checked the residual, and what would clue you to that? I have a weak stream, or I feel like I'm not emptying all the way. Then again, you're worried about making that worse by treating them, so you would want to send them to go to a specialist. I mentioned prior pelvic surgery. If they had recent pelvic surgery a month or two ago, 3 months ago, send them back to the surgeon. You want to make sure that that's not impacting their OAB. But 3 or 4 years ago, I think is fair game. Primary care should be treating that, and then if it doesn't get better, we would see them. Bladder pain is more of an IC picture. Again, send them to the specialist. Neurologic disease, not necessarily going to be improved by a neurologist, the bladder symptoms, so you still may be treating them, but if you're not comfortable with it, then certainly, again, send to a specialist. Next slide. Okay, so we got Anna, who's a 55-year-old female, BMI 29. She's an ex-smoker. She works full-time, factory floor. Sometimes she leaks. She gets a strong urgency. She can't get to the bathroom. She leaks. She wears panty liners. She tends to have to carry pads and panties with her because of that to change. She also seems to be having some menopausal symptoms, fatigue, night sweats, hot flashes. She also just might happen to be pre-diabetic. But on the other hand, she doesn't believe in taking medications. there are ways to deal with this stuff. You know, you have to have that realistic expectation things come into play. If, you know, pelvic floor exercises, better diet, better weight control and stuff may help, but if we can't do that, then we may need to rethink whether I'm not a believer in medications or not. But we certainly have options for them when they want to avoid medications if possible. She's not sexually active. She's doing no therapy for atrophic vaginitis, as the topical estrogen statement says. Next slide. So how do we handle her? We would want to talk to her about lower urinary tract symptoms. What's normal? What's not normal? What part of her symptoms are bladder symptoms and what may be some overlap with some early menopausal symptoms or atrophic vaginitis. If she's waking up at night because of the night sweats, then maybe she needs something more systemic. That's a little bit more out of the scale of what we're talking about, but it's something to at least be talking to her about and pick up on. On the other hand, if she just complains of vaginal dryness and is uncomfortable when she urinates and has some frequency urgency symptoms that's exacerbated by that, then maybe topical estrogen or topical therapy or other options for atrophic vaginitis should be entertained. Going over what her fluids are, what she drinks, making sure she's not drinking too much coffee, caffeinated beverages, the bad stuff that we've talked about. Making sure that when she's at work and she's on the floor, on the factory floor, that she does have access to the bathroom and she's not holding it for prolonged periods of time. Exercise, stress reduction, weight reduction, things to kind of help her deal with her situation and her problems can be helpful. Next slide. Just remember, OAB it's a symptom complex. It's actually not a disease. We think of it as a disease, but it's really a syndrome or constellation of symptoms with got a bunch of differentials that you want to take into account. But it's a fairly easy problem to diagnose. It really does impact patients' lives. We don't give it enough credit. Patients don't go places because their bladders dictate their lives. That's a problem. It's very common. I think 17%, I can't fight evidence, but I'm surprised it's not even higher. Initial diagnosis and treatment, very appropriate for all providers. It does not have to be a specialist to do that. It's easy to make the workup, history, physical exam, urinalysis, maybe a diary if you can get them to do it. Behavioral interventions can be as easy as giving them pelvic floor exercises and instructions on a piece of paper, and as extensive as hooking them up with a specialist or a physical therapist. When done correctly, and when I say that, I really mean patient adherence, you can get a significant reduction. 50 to 75% is not unfounded at all. And that's without, how many therapies do we have that give you that kind of response with outside effects? I mean, let's face it, you're not going to exercise too much. I guess you could. But, that being said, when you have the patients who are not responding, or if your patients are not candidates for pelvic floor therapy, they just don't want to do it, then anticholinergics, beta-3 agonists are second-line therapies that can be used either with the behavioral interventions or as a second-line therapy by itself. Next slide. I think that's it, right?
Great. Thank you again for joining us, Anne and Stephen. Before we end today's webinar, I just have a few important reminders. As I mentioned earlier, please submit your questions to education@arhp.org to have them featured in the second webinar in this series on Frequently Asked Questions. We also invite you to visit arhp.org and register for our upcoming webinar series on hepatitis C. As a reminder, you will receive an email from the ARHP education team in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing your internet browser. If you have questions, again, just email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.